This feels like a full-spectrum deep dive into some of the most challenging, high-stakes areas of the respiratory system.
Absolutely. We're covering everything from chronic management to these acute, life-saving critical care decisions.
And if you want to really move beyond just surface knowledge and truly grasp the mechanics of breathing and, when it fails, this material seems to be the absolute foundation.
It is. We're tackling everything from the molecular mechanisms of asthma drugs all the way up to the precise pressure targets you need for mechanical ventilation and ARDS.
It's so much more than just gas exchange.
Oh, much more. The pulmonary system is really the central nexus for oxygen delivery, CO2 removal, and that incredibly delicate balance of the body's pH.
So for our listener, if you're looking for the shortest path to understanding the history, the exact diagnostic criteria, and the specific decision tree treatment regimens that are in these sources, you are in the right place.
That's the mission. We're going to synthesize these details across the 4 major pillars.
Obstructive, restrictive, vascular, and infectious diseases.
Exactly. And we have to start at the very beginning with the foundational distinction that really dictates 90% of the diagnostic path.
How to interpret pulmonary function tests.
Yes. We have to immediately establish the difference between diseases that block the tubes, the airflow, and those that stiffen the tissue, which is a volume problem.
Okay, let's dive straight into the mechanics of breathing failure.
Let's do it.
So, section 1. Let's unpack this core concept, obstructive lung disease. The definition you pulled is elegant in its simplicity, but the consequences are just enormous.
Right. It's characterized by airway narrowing or collapse.
And that fundamentally causes impaired expiration. So you can get the air in, but you really struggle to push it out.
That's the whole game. And this leads directly to the core problem in all obstructive diseases.
Air trapping.
Air trapping. That difficulty in exhaling is the key physiological hallmark. And we quantify this using spirometry, which measures the dynamic flow of air.
And the numbers here basically become the definition.
Exactly. We look at the forced expiratory volume in 1 second. That's FEV1.
How much air you can force out in that first second.
Right. Relative to the forced vital capacity, or FVC, which is the total amount of air you can force out after taking the deepest possible breath.
And the critical defining number is that ratio, FEV1 divided by FVC.
Yes. And the source is explicit here. An obstructive ventilatory defect is characterized by an FEV1-FVC ratio of less than 70%.
So why is that ratio low? It's because the obstruction means the FEV1, that first second volume, drops way more than the total volume does.
Disproportionately. Think of it like this. The FVC might drop a little, but the FEV1 just plummets because the airways are literally collapsing under the positive pressure of you trying to force the air out.
It's a dynamic compression problem.
Precisely. You just can't achieve the expected flow rate.
So if we immediately contrast that with the other major category restrictive disease, the flow measurement looks totally different. Why does restriction, where the lung is small and stiff, give you a ratio that looks normal or even, a little high, greater than 70%?
Because in restriction, the pipes themselves are usually fine. The problem is the lung tissue is stiff, or maybe the chest wall is constrained. So you have less total volume, a low FVC.
Okay.
But because the airways are actually held open by that surrounding stiffer tissue, you can expel the smaller total volume quite rapidly.
So FEV1 and FVC both go down, but they go down together.
Yeah.
Proportionally.
So the ratio stays normal. It's a small but fast pattern compared to the obstructive big but slow pattern.
That's a great way to put it. Now, to really visualize the clinical consequences of this, we need to look at how it changes the lung volumes. We're looking at figure 2.141, which breaks down all the components.
Right. You've got your tidal volume, inspiratory and expiratory reserve volumes, and the really critical one here, the residual volume, or RV.
And in obstructive disease, because the patient can't fully exhale, that trapped air gets added to the residual volume.
That trapped air is the core issue. It's the air left in your lungs after you've tried to breathe out as much as you possibly can.
And since RV is, by definition, part of the total lung capacity, the TLC, then the TLC also has to increase.
Exactly. The patient with severe obstruction, especially someone with emphysema, lives in a state of chronic hyperinflation. Their lungs are physically bigger, but it's all inefficient, stale, trapped air.
Which is why they're so breathless. They have to breathe at this mechanically disadvantaged high lung volume.
Right. The diaphragm gets flattened. It can't contract efficiently. It's a terrible cycle.
This whole high volume, low flow state is captured perfectly by the flow volume loop in figure 2.14-2. This visual is, it's mandatory for understanding these patterns.
It really is. If you look at a normal loop, the part where you breathe out, the expiratory phase, is a smooth, convex curve. It rises fast and maintains flow.
But when you superimpose an obstructive loop, the picture is completely different.
It's fundamentally shifted to the left, which shows that increased TLC and RV we just talked about. But the shape of the expiratory curve is the dead giveaway.
It's deeply scooped out.
That's the word. That scooped out shape visually represents the dynamic collapse of the airways during the forced expiration maneuver. It causes the flow rate to just drop off a cliff dramatically and prematurely.
And then the restrictive loop, for comparison.
Since all the volumes are decreased, the entire loop is just shrunken. It looks like a miniature version of the normal one. It's shifted a bit to the right, reflecting the lower TLC, RV, and FVC.
But the shape of that expiratory curve, the slope, is generally preserved.
Or even steeper. It shows that the flow rate relative to the small size is still good. So that simple visual cue is an incredibly fast way to distinguish the pathophysiology.
Okay, let's move to the prototype obstructive disease, asthma. The definition here is key. Reversible airway obstruction.
Right, secondary to inflammation, bronchial hyperreactivity, and often smooth muscle hypertrophy. It's all about those episodic symptoms, the cough, the wheezing, the dyspnea.
The episodic nature is so critical, right?
Yeah.
That's what really distinguishes it from the chronic fixed obstruction of COPD.
Exactly. And when you're evaluating a patient, especially in an acute attack, you're looking for signs of how severe it is. Wheezing is classic, obviously.
But a quiet chest can be an even worse sign.
A very grave sign. It can mean the obstruction is so severe that almost no air is moving at all.
And the high-yield physical finding you pointed out is pulsus paradoxus. Can you walk us through that? The drop in systolic blood pressure of more than 10 mmHg during inspiration.
It's a sign of really severe disease, and it's a great example of cardiorespiratory interaction. Let's just dissect the mechanism for a second.
Please do.
During a massive asthma attack, the patient is breathing against such extreme resistance that they have to generate these hugely negative intrathoracic pressures just to get air in.
Okay.
At the same time, their lungs are hyperinflated, which is physically compressing the pulmonary blood vessels.
So how does that combination affect the heart?
It's a double whammy. The increased negative pressure and the vessel compression dramatically impede venous return to the left side of the heart.
So less blood is getting back to the left ventricle.
Momentarily, yes. So the left ventricle receives less blood, causing a transient but significant drop in its stroke volume and therefore systolic pressure precisely during inspiration.
So that 10 millimeter drop isn't just a number.
No, it's the heart screaming under the strain of the obstruction. It's a sign that the patient is truly, truly struggling.
Wow. Okay, so diagnosis. It rests on proving that reversibility. Spirometry is the best initial test, showing that obstructive pattern.
But the proof is in the response to treatment. You're looking for a significant improvement after a short-acting beta agonist, a SABA.
And significant is defined very specifically here. A greater than or equal to 12% and a greater than or equal to 200 milliliter increase in FEV1.
Correct. Now, what if the patient's baseline spirometry is normal, but you still really suspect asthma? Say they only have exercise-induced symptoms.
Then you move to the confirmation test, the methacholine challenge.
Right. Methacholine is an inhaled agent that is a direct bronchoconstrictor. You're basically trying to provoke an attack in a controlled setting.
And a positive test, which confirms that bronchial hyperresponsiveness is defined as a 20% or greater decrease in FEV1 after the challenge. You're forcing the airways to spasm to prove the diagnosis.
Now let's talk about maybe the single most crucial life-saving insight in managing an acute asthma attack, the paradox of the acid-base status. This is where clinical vigilance really pays off.
Okay, walk us through the progression.
When an asthmatic patient first comes in, they are terrified, they're breathless, and they're using every muscle they have just to breathe. They are hyperventilating.
They're blowing off CO2.
Faster than their body is producing it. And since CO2 is acidic, rapid CO2 exhalation leads to a state of respiratory alkalosis, low PaCO2, high pH.
So that alkalosis is actually a sign of the patient's strong compensatory effort. They're still fighting.
Exactly. But this compensation is exhausting. You can only sustain that maximal respiratory effort for so long. If the obstruction is severe and you don't relieve it, muscle fatigue is inevitable.
And when they get tired, they can't maintain that hyperventilation against the massive resistance.
And they start trapping CO2.
The whole clinical picture flips.
It flips. The PaCO2 rapidly rises, and the pH plummets towards respiratory acidosis. High PaCO2, low pH. This shift from a chaotic, alkalotic, hyperventilating patient To a patient who seems calmer, quieter, and is now acidotic, that is the most dangerous sign in the emergency room.
Because it means impending respiratory failure.
It often means they need to be intubated immediately. You have to be trained to recognize that the patient who looks calmer is actually closer to death.
That is a phenomenal piece of high-yield clinical synthesis. Let's shift now to treatment. The pharmacopoeia for asthma is detailed in Table 2.14, 8 major classes.
And we need to understand why we combine these drugs. You need agents that relax the muscle, agents that reduce the underlying inflammation, and agents that block the downstream chemical mediators.
Okay, starting with muscle relaxation. The beta agonists, SABA and LABA.
The mechanism is smooth muscle relaxation by stimulating the beta-2 adrenergic receptors. SABAs, like albuterol, are fast onset, short-acting. They are purely for rescue.
And LABAs, like someterol, are slower onset but long-acting. They're only for maintenance.
And never used alone in asthma. That's a huge safety point. They must be paired with an inhaled corticosteroid, an ICS.
Which brings us to the foundational long-term control agents, the corticosteroids.
First line for long-term control. They attack the root cause, the inflammation. They work by inhibiting the synthesis of cytokines and just dampening that whole inflammatory cascade.
They don't relax muscles.
No, they reduce the hyperresponsiveness over time.
Next up, the muscarinic antagonists, SAMA and LAMA.
Agents like ipratropium. They work by competitively blocking the muscarinic M3 receptors on the bronchial smooth muscle. This interrupts the parasympathetic signal that tells the muscle to constrict.
Often used with beta agonists, especially in acute attacks.
A great synergistic effect. Then you have the older class, methylxanthines, like theophylline.
This one causes bronchodilation by inhibiting phosphodiesterase, which leads to increased intracellular CAN-MP. What's the major warning here?
Its narrow therapeutic index. Theophylline can cause severe cardiotoxicity, arrhythmias, and neurotoxicity, like seizures.
So you have to meticulously monitor the plasma levels.
Which is why it's a third or fourth line agent today. It's just too risky otherwise.
The next 4 classes target specific inflammatory mediators. Cromolyn is unique.
It is. It prevents the release of vasoactive mediators from mast cells by stabilizing their membranes. It's excellent for preventing attacks, like before exercise, but it's useless once an attack is already happening.
Then the anti-leukotrienes. These are key. Leukotrienes are powerful bronchoconstrictors.
And we have 2 ways to attack them. Xyloton inhibits the enzyme 5-lipoxygenase, so it stops the synthesis of leukotrienes from arachidonic acid entirely.
Whereas montelukast and zafirlukast just block the leukotriene receptors.
Exactly. Different mechanisms, same pathway.
For severe ophthalmologic asthma, we turn to the biologicals. Anti-IgE therapy, omalizumab.
This is a monoclonal antibody that targets circulating IgE. By blocking IgE from binding to mast cell receptors, it prevents the whole type I hypersensitivity reaction from even starting.
And the final, highly specialized biologicals, target eosinophils, which drive inflammation in certain severe types of asthma.
Right. Anti-IL-5 like mepolizumab and anti-IL-5R like benralizumab. These are monoclonal antibodies that block the cytokine interleukin-5 or its receptor.
So they stop the production and recruitment of those inflammatory eosinophils.
It's very targeted therapy. And that detailed mechanistic map is crucial for management, which brings us to the GINA treatment guideline in Table 2.143.
And this has really revolutionized asthma care.
It has, by prioritizing that anti-inflammatory protection even in the mildest disease. The core philosophy shift is the use of an ICS formoterol combination inhaler as the preferred reliever at all steps.
So you get anti-inflammatory benefit every single time you need rescue bronchodilation.
Exactly. So let's walk through the steps. Step 1 is for patients with very infrequent symptoms, less than twice a month. Instead of just a SABA, the preferred treatment is as-needed low-dose ICS formoterol.
They get steroids every time they use their rescue inhaler.
Right. Then, as symptoms become more frequent, you go to step 2. The patient moves to daily maintenance, which is a low-dose ICS formoterol used for both maintenance and as the reliever. It's a dual-purpose approach.
Then step 3 ramps up the maintenance dose to a low-dose ICS LABA.
Right. This is usually a daily ICS LABA, often with a separate SABA for rescue, unless the patient is still on that ICS formoterol reliever strategy.
Step 4 is the next big escalation. Medium to high-dose ICS LABA. You're maximizing inhaled therapy here.
Before you add systemic complexity, which is step 5. This is for severe refractory asthma. Here, you maintain the high-dose ICS LABA, and you introduce a biological agent.
Anti-IgE, anti-IL-5, tailored to the specific inflammatory markers of that individual patient.
It's a really structured, logical step-up approach. It's the modern standard of care.
All right, shifting gears to COPD, which is the definition of fixed airflow limitation. It's a decrease in lung function that is non-reversible.
And we divide this syndrome into the clinical definition of chronic bronchitis and the pathological diagnosis of emphysema.
Chronic bronchitis is a diagnosis based on history, right? A productive cough at least 3 months a year for 2 consecutive years.
Pathologically, it's about hypertrophy of the mucus glands and inflammation of the large airways. This leads to obstruction and impaired clearance.
Emphysema, on the other hand, is defined by permanent enlargement of the air spaces distal to the terminal bronchiole, with destruction of their walls. The critical loss there is elastic recoil.
That destruction of the gas exchange surface is the key distinction. And when we talk about these two, the sources reinforce those classic phenotypes, the pink puffer of emphysema versus the blue bloater of chronic bronchitis.
These caricatures, while maybe a bit oversimplified, they do highlight some really crucial pathophysiological differences.
They do. Let's break down the pink puffer first. Because they lose that elastic recoil, they have to work extremely hard to exhale. You often see them using pursed lip breathing.
To create a kind of internal peep to stint the airways open.
Exactly. And they're generally thin, cachectic, because of the high caloric cost of breathing.
But critically, they manage to maintain relatively normal blood gas levels until very late in the disease.
Right. They retain their hypoxic drive longer. They're pink because they aren't profoundly cyanotic until failure is imminent. They are compensating like crazy, but they're wasting away in the process.
Now, the blue bloater, chronic bronchitis, is different.
They have chronic airway inflammation, a lot of VQ mismatch. They start to develop hypoxemia and hypercarbia much, much earlier in the disease course.
And their persistent hypoxemia causes pulmonary vasoconstriction,
which leads to pulmonary hypertension and eventually right-sided heart failure, cor pulmonale.
So that fluid retention and the early hypoxemia lead to that bloated and blue cyanotic appearance.
And they are often overweight and very prone to infectious exacerbations.
Diagnosis, again, requires spirometry. FEV1, FVC, less than 70%. The absolute key here is demonstrating that this ratio is non-reversible after a SABA challenge.
That's what separates it definitively from asthma. And we also use the diffusing capacity of the lung for carbon monoxide, the DLCO, as a secondary tool.
How does that help?
The DLCO is severely decreased in emphysema because the alveolar capillary surface where the gas exchange happens is literally destroyed. In chronic bronchitis, the gas exchange unit itself is largely preserved, so the DLCO might be near normal, at least early on.
Okay, so management. It's stratified using this combined assessment of symptoms and exacerbation history, mapping patients into groups A, B, C, or D.
Right. It shifts the focus from just the spirometry stage to the functional risk of the patient. It's about personalization. Group A, patients, mild symptoms, low risk, they get the least. Often just a SABA or SAMA as needed.
But if you jump to the most complex, Group D, severe symptoms, high risk, they need immediate combination therapy.
Initial therapy is typically a LAMA plus a LABA. Or if they have features of asthma or high eosinophil counts, a LAMA plus an ICS.
And 3 treatment pillars transcend all these groups and are proven to improve survival.
1, aggressive, absolute smoking cessation.
2,
required immunizations, influenza, and pneumococcal vaccines.
And the 3rd, and this is the complex one, supplemental oxygen. When is long-term oxygen therapy indicated, and what's the specific risk we have to manage?
LTOT is indicated for chronic severe hypoxemia, specifically a PaO2 consistently at or below 55 or an SSO2 at or below 88%.
And the risk?
The physiological risk is the loss of the hypoxic drive. In patients with chronic high CO2, the body adjusts and starts relying on low oxygen levels to stimulate breathing.
So if we give them too much oxygen,
we remove that hypoxic stimulus. Their respiratory drive diminishes, they breathe even less, they trap even more CO2, and you can push them into a life-threatening acute respiratory acidosis.
Which leads us right into managing acute exacerbations.
This requires aggressive escalation. The treatment package involves inhaled bronchodilators, systemic corticosteroids, and often antibiotics.
Antibiotics are crucial if there are infectious signs. The criteria are 2 or more of the cardinal symptoms, right?
Increased dyspnea, increased sputum production, or increased sputum purulence. Common targets are mugs like H. influenza.
Now, when the patient progresses to acute hypercapnic respiratory failure, this is the critical juncture. The sources emphasize that non-invasive positive pressure ventilation, NPPV, is the preferred initial method.
NPPV using BiPAP or CPAP helps blow off that trapped CO2 and reduces the patient's work of breathing without all the risks of intubation.
So you avoid things like hospital-acquired pneumonia or vocal cord injury.
But it's not for everyone. The contraindications are strict.
Like you.
Any patient who can't protect their airway or tolerate the mask. So altered mental status, active GI bleeding with risk of aspiration, recent facial trauma, or profound hemodynamic instability.
If NPPV fails, or they meet one of those, then you have to intubate.
No choice. And the oxygen target, which is so counterintuitive, must be reiterated for the acute COPD patient. You titrate the SpO2 to a very specific narrow window of 88 to 92%.
Intentionally lower than for a normal patient.
It's a necessary compromise. You're trying to ensure sufficient oxygenation while maintaining just enough residual hypoxic drive to prevent that life-threatening hypercapnia.
We've thoroughly mapped the airflow problem. Now we transition to the structural issue.
Right.
Restriction. So, restrictive lung disease is about mechanical failure, low lung compliance, restricted expansion, decreased volumes.
And it's fundamentally defined by a low total lung capacity, or TLC. Remember the spirometry pattern from section 1? The hallmark of restriction is low volume, not low flow.
So the FEV1-FVC ratio is either normal or even increased. They move less air, but they move it quickly.
Exactly. And the causes are incredibly diverse. The mnemonic provided ain't compliant helps organize this.
So that's alveolar filling processes, idiopathic, or infections.
Right, like ILD, and neuromuscular issues like ALS or myasthenia gravis, thoracic wall problems like obesity or kyphoscoliosis, and systemic diseases.
Let's focus on the most common internal cause, interstitial lung disease, or ILD.
This is a whole group of diseases characterized by chronic inflammation and or progressive fibrosis of the interstitium, the scaffolding around the alveoli.
And the clinical presentation reflects that mechanical difficulty. Patients have shallow, rapid breathing.
Dyspnea. They're trying to keep their stiff lungs recruited. They have a non-productive, dry cough.
And the physical exam clue is unique. Those classic Velcro-like crackles or fine rails at the lung bases.
That sound is very specific. It's the sound of the peripheral airways, which have been closed by the fibrosis, snapping open rapidly on inspiration. It's highly suggestive of ILD, especially idiopathic pulmonary fibrosis, IPF.
When you suspect ILD, what's the best imaging and what are you looking for?
Best next step is a high-resolution CT, an HRCT. You're looking for architectural distortion from the fibrosis. In advanced disease, the characteristic finding is honeycomb lung.
Clusters of fibrotic cysts and dilated air spaces that have just replaced the normal lung.
It usually signifies a poor prognosis, especially in IPF. Biopsy is a last resort due to invasiveness.
And treatment is mainly supportive, with oxygen. For IPF, the focus has shifted from steroids to novel antifibrotic agents like pirfenidone and nintedanib.
They don't cure it, but they aim to slow the inevitable progression of the scarring.
One of the great imposters in medicine that can cause restriction is sarcoidosis.
It's defined by the presence of non-caseating granulomas, these organized inflammatory nodules, but without the necrotic, cheesy center you see in TB.
The demographics are important here. It commonly affects young adults, particularly those of African American and Northern European descent.
And the sources give us the true mnemonic to organize the multi-system involvement. Beyond the systemic symptoms, we look for involvement in the CNS, the eyes,
Uveitis.
the skin erythema nodosum, those painful red nodules on the shins, the liver, the kidney, and of course, the major target, the lung and the lymphatics.
And the classic imaging finding is unmistakable. Bilateral hilar lymphadenopathy on a chest X-ray, often called potato nodes.
It's a classic. PFTs show the restrictive pattern and decreased DLCO. And diagnostically, we look for secondary biochemical markers.
Elevated serum angiotensin-converting enzyme, or ACE, levels.
Suggestive. As is hypercalcemia or hypercalciuria. This happens because the macrophages in the granulomas have 1-alpha hydroxylase activity, leading to unregulated synthesis of active vitamin D.
Which dries up calcium absorption.
Exactly. Treatment hinges on symptom severity. If they're asymptomatic, you observe. Spontaneous remission is common. If there's significant organ involvement, systemic corticosteroids are the primary treatment.
And to a different inflammatory mechanism, hypersensitivity pneumonitis. This isn't an infection.
No, it's an intense immunological reaction in the small airways and alveoli. It's caused by chronic inhalation of organic dust.
The classic causes are what?
farmer's lung from moldy hay, and bird fancier's lung from avian droppings and proteins.
And diagnosis relies heavily on the temporal history. The classic description is a patient getting recurrent fevers, chills, malaise, and a dry cough.
Consistently 4 to 6 hours after a specific exposure, like cleaning the chicken coop.
Treatment is often curative, but it requires absolute avoidance of whatever is causing it.
If the inflammation is severe, you might use corticosteroids temporarily, but long-term success is all about environmental control.
All right, this next section is a highly specific intersection of history, industry, and pathology. Pneumoconioses or occupational lung diseases.
And the precise details here, the exposure, the location in the lung, the specific imaging findings, these are critical high-yield facts.
Let's start with asbestosis. Exposure is to asbestos fibers, historically from insulation, shipbuilding, pipe fitting.
The latency period is long, often 15 to 20 years before symptoms show up. The imaging findings are characteristically found at the lung bases.
You see linear opacities, but the most specific finding, which are benign markers of exposure, are the pleural plaques.
Dense, calcified, dome-shaped lesions on the parietal pleura. But the complications are the real danger.
Twofold. The development of lung cancer, especially if the patient smokes.
And the profound, rare risk of mesothelioma, a highly aggressive cancer of the pleural lining.
Next, coal workers' disease, or black lung. Exposure is chronic inhalation of coal dust in underground miners.
Imaging shows small, rounded, nodular opacities, mostly in the upper lung zones. The complication you worry about is progression to progressive massive fibrosis, or PMF.
Big, dense scars that severely impair lung function.
Then there's silicosis, exposure to crystalline silica dust from mining, quarrying, sandblasting, glass, and pottery work.
Like coal, it causes small nodules in the upper lung zones. But the diagnostic home run on imaging is the presence of eggshell calcifications.
Calcification rings around the hilar lymph nodes. It's a classic finding for silicosis.
Beyond the fibrosis itself, the specific complication for a silicosis patient is the elevated lifelong risk of tuberculosis.
This is a mechanistic connection. Silica particles are eaten by alveolar macrophages, but they impair the macrophage's ability to kill the Mycobacterium tuberculosis.
Which means you have to mandate annual TB screening for all patients with silicosis.
Absolutely. Finally, berylliosis. This is a more modern exposure from high-tech fields like aerospace and nuclear manufacturing. It acts a lot like sarcoidosis,
causing non-caseating granulomas.
Imaging shows diffuse infiltrates and hilar adenopathy. Because of its immune-mediated nature, the standard treatment, unlike for the others, is chronic systemic corticosteroids to suppress that granulomatous inflammation.
We're transitioning now to acute life-threatening failure. The definition of hypoxemia is key for this section. PaO2 less than 60 or SO2 less than 90%.
And when a patient is failing, the first diagnostic step is figuring out why the oxygen is low. That determination rests on calculating the alveolar arterial, or AAA, gradient.
This gradient tells us if the problem is poor oxygen uptake across the lung membrane itself, or if there's just not enough oxygen getting to the lung in the first place.
Exactly. The A gradient is the difference between the theoretical oxygen pressure in the alveoli and the measured pressure in the arterial blood. A normal gradient is small.
If the calculated gradient is normal, the gas exchange unit is working perfectly. The hypoxemia must be due to insufficient effort, like hypoventilation from an overdose, or low ambient oxygen at high altitude.
And the clinical consequence of a normal gradient is that the hypoxemia is easily correctable with supplemental oxygen.
But if the gradient is increased, that means the lung itself is failing to transfer oxygen effectively.
You're looking at a VQ mismatch, like in COPD or PE, or critically, a shunt.
A shunt means blood is just bypassing the ventilated lung entirely.
Think of severe pulmonary edema, or ARDS, where the alveoli are filled with fluid. Oxygen can't touch the blood. Shunt-related hypoxemia is highly refractory to oxygen therapy. You can blast them with 100% O2, but if it can't reach the capillary, the saturation barely budges.
Which brings us to acute respiratory distress syndrome, ARDS. This is non-cardiogenic pulmonary edema, defined by that refractory hypoxemia and severely decreased lung compliance.
The specific definition requires a PaO2 to high O2 ratio of less than or equal to 300. It indicates massive gas exchange failure. The mortality is still terrifyingly high, 30 to 40%.
Pathologically, it's diffuse alveolar damage driven by overwhelming systemic inflammation. Sepsis is the most common cause.
And treatment hinges first on managing that primary cause, treating the sepsis, stopping the trauma. But the central strategy, and the one we have to detail fully, is the approach to mechanical ventilation.
Ventilation for ARDS is a paradigm of lung protective strategy. The goal is minimizing ventilator-induced lung injury, or VILA.
This means we must strictly enforce low tidal volumes, specifically 6 cc's per kilogram of ideal body weight.
Why ideal body weight and not actual weight?
Because your lung size is determined by your height and sex, not by how much you weigh.
Yeah.
Pushing 12 cc's per kilo into the lung of a patient who's 300 pounds but 5'4" would cause guaranteed volute trauma,
You'd be overstretching and injuring the functional lung tissue.
triggering local inflammation and making everything worse. That 6 cc per kilo goal is sacrosanct.
And we use PEEP, positive and expiratory pressure. Why is PEEP so vital in the ARDS patient specifically?
PEEP recruits collapsed alveoli and keeps them open. It prevents the cyclical collapse and reopening that causes atelic trauma, which just tears the delicate tissue apart. We titrate PEEP to maintain a target PO2 of at least 55.
The sources also detail a highly effective non-ventilator strategy, proning, placing the patient on their stomach. How does that improve VQ matching?
In a patient lying on their back, the dependent posterior lung regions often collapse under the weight of the heart and abdomen, but they're still heavily perfused. That causes a massive shunt.
So by proning them.
You redistribute the weight. You often recruit those previously collapsed posterior lung zones, improving VQ matching and oxygenation without having to crank up the ventilator pressures. It's a physical solution to a gravitational problem.
Okay, let's get into the mechanics of mechanical ventilation itself. Let's define the 4 critical pressure measurements the ventilator gives us.
Interpreting these pressures is essential for identifying the patient's pathology and protecting them from villi. The first is the one you see most easily, peak inspiratory pressure, or P-peak.
This is the max pressure reached inside the airway during a breath. It reflects the total pressure needed to overcome everything.
Right, the resistance of the tubes, the stiffness of the lung, and the PEEP you started with.
The second, and arguably the most important for villi prevention, is the plateau pressure, or P-plat. How is that measured, and what does it represent?
P-plat is measured by briefly stopping the airflow, an inspiratory hold at the end of inspiration. Since there's no flow, the resistance component drops to 0. So P-plat reflects only the pressure required to distend the alveoli.
So it's a direct measure of the compliance or stiffness of the lung tissue.
Exactly. P-plat equals the elastic pressure plus peak.
So if P-peak is the total work, and P-plat is the lung stiffness, the difference between the two has to be the resistance.
Correct. The third measurement, resistive pressure, is just P-peak minus P-plat. This reflects the resistance to airflow through the airways and the ventilator tubing.
And the fourth is PEEP, the baseline pressure keeping the alveoli from collapsing.
Now let's solidify why those pressures are the keys to avoiding PEEP. High tidal volumes cause voli trauma, but high pressures cause barotrauma.
Specifically, if the plateau pressure, P-plat, exceeds 30 centimeters of water.
The alveoli are being overstretched and are at high risk of rupture, leading to a pneumothorax. We manage the tidal volume to keep P-plat below 30.
And the cyclical opening and closing of collapsed units is atelic trauma, which is what PEEP helps mitigate.
Another acute, life-threatening complication of ventilation is Sutter hypotension. This is frequently PEEP-induced. High levels of PEEP dramatically increase the overall intrathoracic pressure.
And the mechanical result of that.
It creates a pressure bottleneck. It impedes venous return to the right atrium and consequently reduces the filling of the ventricles, the preload.
Decreased preload means decreased stroke volume, which means decreased cardiac output and acute hypotension.
So when a patient on high KEEP suddenly crashes hemodynamically, the first step is often to momentarily decrease the PEEP while you stabilize them with fluids or pressors.
This pressure analysis lets us interpret the pathologic waveforms. Let's visualize the 2 major scenarios. A problem with the pipes versus a problem with the lung tissue.
Scenario 1. Increased resistive airway pressure. This is a problem with the pipe's resistance has gone up. On the pressure time graph, the P-peak shoots up dramatically, but when you do the inspiratory hold, the plateau pressure remains normal.
The widening gap between P-peak and P-plat tells you the issue is airflow resistance.
Clinically, this is a mucus plug, severe bronchospasm, or a kinked endotracheal tube. The treatment has to be directed at the resistance, bronchodilators, suctioning the plug, untwisting the tube.
Scenario 2. Decreased compliance. This is a problem with the lung tissue itself. It's stiff. On the graph, both the P-peak and the plateau pressure rise together, maintaining the same difference between them.
This is the problem of stiffness. Pathologies include pulmonary edema, ARDS, massive pneumonia. The lungs are hard to inflate. Treatment involves addressing the stiffness, diuretics for edema, or the low tidal volume strategy for ARDS because we cannot let that p-plat exceed 30.
Understanding those two waveform shifts is fundamental to managing a patient on a ventilator.
Let's talk about the pulmonary circulation. Its failure is catastrophic. Pulmonary hypertension, or PH, is defined as chronically elevated pressure in the pulmonary artery, a mean pressure of 20 millimeters of mercury or more at rest.
And the functional classification, groups 1 through 5, is essential because treatment depends entirely on the underlying cause.
Exactly. Group 1 is pulmonary arterial hypertension, PAH, which is primary or idiopathic. Group 2 is the most common cause globally, PH secondary to left-sided heart disease.
The pressure just backs up from the left atrium into the pulmonary veins.
Group 3 is PH secondary to lung diseases or hypoxemia, which is directly relevant to what we've been discussing. COPD, ILD, sleep apnea. Chronic hypoxia causes reactive vasoconstriction.
And group 4 is chronic thromboembolic pulmonary hypertension.
This is the perfect pivot to cor pulmonale. This is defined specifically as right ventricular hypertrophy or failure caused by a primary disorder of the respiratory system. It's essentially group 3 PH leading to RV failure.
And the clinical presentation is that of right-sided congestive heart failure.
You see signs of systemic venous congestion, peripheral edema, hepatomegaly, and most reliably, elevated jugular venous distension or JVD.
On auscultation, the high pressure against the pulmonic valve often results in a loud, accentuated P2 heart sound.
And possibly a tricuspid regurgitation murmur due to the RV dilating.
Diagnosis begins with the best initial test, the echocardiogram.
It lets us estimate the pulmonary artery pressures and visually assess the right ventricular function, but the gold standard remains right heart catheterization.
An invasive procedure that gives you direct, accurate measurements.
It confirms the diagnosis. Treatment depends on the group. For groups 2 and 3, you treat the underlying cause, optimize the heart failure, maximize the bronchodilation.
But for group 1, primary PAH, we use specialized vasodilators.
Right. Things like prostacyclin analogs, endothelin receptor antagonists, because endothelin is a powerful vasoconstrictor, and phosphodiesterase inhibitors like sildenafil.
A major time-sensitive vascular emergency is pulmonary thromboembolism, or PE, obstruction of the pulmonary vasculature, overwhelmingly caused by a clot from a deep venous thrombosis, a DVT.
And the ability to predict a PE starts with understanding its preconditions, famously summarized by Virchow's triad: venous stasis, endothelial injury, and hypercoagulability. This is the mechanism of nearly every DVT-PE.
Let's give some specific clinical examples. Venous stasis is caused by prolonged immobility, like a long flight or bed rest, obesity, or CHF.
Endothelial injury occurs from trauma, surgery, especially hip or knee replacement, or a central line. Hypercoagulability can be genetic, like factor V Leiden, or acquired, like from malignancy, oral contraceptive pills, or pregnancy.
The clinical presentation is highly variable, from acute dyspnea and pleuritic chest pain to syncope and cardiovascular collapse.
So we have to quantify the clinical suspicion using the modified Wells criteria. This helps us avoid unnecessary imaging in low-risk patients while making sure high-risk patients get treated urgently.
The highest weight is given to the physical exam. 3 points for signs or symptoms of a DVT, and 3 points if PE is deemed the most likely clinical diagnosis.
Other criteria, worth 1 to 1.5 points, include tachycardia, immobilization, prior history of PE or DVT, hemoptysis, and active cancer. A score over 4 suggests PE is clinically likely.
And the diagnostic flowchart flows directly from that score. If the patient is low or moderate risk, the very best initial test is the D-dimer.
This test measures fibrin degradation products, but it's only useful when it's negative.
Why is that?
Because it's highly sensitive but not specific at all. If the D-dimer is negative, you can reliably rule out a PE. If it's positive, it just means a clot is forming or breaking down somewhere. It could be a bruise, surgery, anything. A positive D-dimer has to be followed by definitive imaging,
Which is the CT pulmonary angiogram, or CTPA.
That's the gold standard. You inject contrast to visualize the filling defects from the clots. If the patient has a contraindication to contrast, like severe renal failure, the alternative is a VQ scan.
And as an adjunct, a lower extremity venous ultrasound for DVT.
Right. Since most PEs come from DVTs, finding a proximal DVT is often enough to confirm the need for treatment.
Treatment depends on severity. For most submassive PEs, the standard is acute anticoagulation.
heparin, low molecular weight heparin, or direct oral anticoagulants, the DOACs.
And the inferior vena cava filter, the IVC filter, is reserved for a very specific situation.
Only for patients who have a confirmed PE or DVT, but in whom anticoagulation is absolutely contraindicated, like with active, uncontrollable bleeding.
And the most aggressive intervention, thrombolysis with TPA, is reserved exclusively for a massive PE.
This is a PE causing hemodynamic instability and severe right heart strain, often a large saddle embolus. It's a life or death decision because of the huge risk of catastrophic bleeding.
All right, let's talk neoplasms. A frequent clinical dilemma, often found by accident, is the solitary pulmonary nodule, or SPN.
Right, a single rounded opacity less than 3 centimeters, often asymptomatic. The first goal is risk stratification, benign or malignant.
And the key variables in Table 2.14 and 13 dictate that risk level. Let's detail what pushes a nodule into the high-risk category.
First, size. Nodules bigger than 20 millimeters are very concerning. Second, age. Patients over 60. Third, smoking status. Current smokers or those who quit less than 5 years ago.
Morphological characteristics are just as vital. High-risk features include an irregular or spiculated border, a coronoradiated appearance, or calcification patterns that are irregular or totally absent.
Benign nodules often have uniform or central popcorn calcification.
The management flowchart is defined by this risk assessment. If the SPN is deemed low risk,
Small, young patient, non-smoker, benign calcification, the primary strategy is surveillance, serial CT scans.
and the key time metric here is that if the nodule is stable for more than 2 years, the likelihood of malignancy is extremely low.
Surveillance can typically be stopped. But if the nodule is high risk, meaning malignancy is overwhelmingly likely, the default is often immediate surgical resection.
And for intermediate risk,
You proceed to further investigation, typically a PET scan because malignant tissue is metabolically active, or definitive biopsy.
moving on to lung cancer itself, tragically the leading cause of cancer death in the U.S.
Main culprits are tobacco smoke, but also environmental exposures like radon and asbestos. We strictly divide it into small cell lung cancer, SCLC, and non-small cell, NSCLC,
We treat them almost entirely differently.
which is why the distinction is fundamental. Small cell lung cancer, or small oat cell carcinoma, is almost exclusively seen in heavy smokers. Its characteristics are poor.
It's typically located centrally, a hilar mass, grows incredibly fast, and has the worst prognosis because of early massive metastasis.
It's neuroendocrine in origin, which makes it notorious for producing peptides that cause these specific systemic effects, known as perineoplastic syndromes.
We have to detail these. SCLC is linked to the syndrome of inappropriate antidiuretic hormone, SIADH, which causes hyponatremia.
It can also cause Cushing syndrome from ectopic ACTH production. And the highly specific neurological syndrome is Lambert-Eaton myasthenic syndrome.
An autoimmune response where antibodies attack the presynaptic calcium channels, impairing acetylcholine release.
Clinically, it causes proximal muscle weakness that paradoxically improves briefly with sustained activity.
Contrasting this, we have the non-small cell lung cancers. The most common overall and the most common in non-smokers is adenocarcinoma.
It's typically located peripherally, and this is the type most frequently associated with activating oncogene mutations like EGFR and ALK.
Then, squamous cell carcinoma, highly correlated with smoking, and like SCLC, it's typically located centrally. Its defining perineoplastic syndrome is hypercalcemia.
Right, it secretes parathyroid hormone-related protein, PTHrP, which mimics PTH, leading to high calcium.
There's also large cell carcinoma, which is poorly differentiated and has a poor prognosis. A localized but dramatic complication we have to remember is superior vena cava syndrome.
This is compression of the SVC by a centrally located tumor, usually SCLC or squamous cell. The obstruction causes severe backup.
Facial and upper trunk swelling, jugular venous distension, headache. It's an emergency.
Requires immediate radiation or chemotherapy. Finally, treatment nuances. Because SCLC is so aggressive and widely metastatic at diagnosis, surgery is almost never an option. Chemo and radiation are the mainstays.
NSCLC, on the other hand, is often amenable to curative treatment in early stages. Surgery is the preferred option.
And in advanced stages, we utilize tailored precision medicine-targeted therapies for those EGFR mutations, and increasingly, immunotherapy with checkpoint inhibitors.
Let's move into the microscopic battle. Respiratory tract infections. The most frequent is pneumonia, or PNA.
And it's crucial to distinguish between typical and atypical bacteria. Typical bacteria cause that classic acute presentation: high fever, shaking chills, productive cough, and a lobar consolidation on the chest X-ray.
The most common cause overall is Streptococcus pneumonia.
Atypical bacteria cause a more insidious presentation, so-called walking pneumonia, gradual onset, dry cough, systemic symptoms. This includes mycoplasma, chlamydia, and legionella.
The clinical scenario provides major clues. If the patient is a heavy alcohol user or prone to aspiration, we worry about gram-negatives like Klebsiella.
Which causes that characteristic current jelly sputum, or polymicrobial anaerobic infections.
In patients with underlying COPD, we have to cover for pathogens that colonize their damaged airways, like H. influenza.
And if the COPD is advanced or they have bronchiectasis, you have to consider Pseudomonas.
And in the immunocompromised, especially patients with advanced HIV CD4 count under 200, the suspicion immediately leaps to opportunistic pathogens.
Pneumocystis jirovecii, PCP, and Mycobacterium tuberculosis.
Diagnosis begins with a chest X-ray. But for management, we rely heavily on the COB65 criteria to assess severity and decide where to treat the patient.
Right. The CORB65 mnemonic stands for confusion, urea BU over 19, respiratory rate over 30, blood pressure that's low, and age 65 or older.
And the score is essential for triage. A score of 0 or 1, outpatient treatment. 2, you admit them to the ward. 4 or more means high mortality risk and ICU admission.
And this stratification determines the empiric antibiotic regimen. For a healthy outpatient, it's simple: amoxicillin, doxycycline, or a macrolide.
For an inpatient on the ward, you need broader coverage. A beta-lactam like ceftriaxone plus a macrolide like azithromycin.
Or a respiratory fluoroquinolone as monotherapy. But the complexity skyrockets for hospital-acquired pneumonia or ICU patients.
Here you need to cover for multi-drug-resistant gram-negatives, especially Pseudomonas, and often add an anti-MRSA agent.
Tuberculosis, caused by Mycobacterium tuberculosis, is a unique challenge because of its global burden and its ability to hide in a latent state.
Risk factors for reactivation include HIV, immunosuppression, and travel to endemic areas.
And the distinction between latent and active TB is the first step. Latent TB is asymptomatic. The patient can't transmit it. It's diagnosed via a positive tuberculin skin test, a TST, or an interferon gamma release assay, an IGRA.
Active TB presents with constitutional symptoms: chronic cough, night sweats, weight loss, maybe hemoptysis. Diagnosis requires demonstrating the organism, a positive sputum acid-fast bacilli, or AFB smear and culture.
Treatment for active TB is long, complex, and toxic. It uses the famous 4-drug regimen, RIPE, for the initial 2-month phase.
Rifampin, isoniazid, presenamide, and ethambutol.
Followed by a 4-month continuation phase of just rifampin and isoniazid. The side effects are mandatory to memorize.
Rifampin causes orange discoloration of body fluids.
You have to warn the patient about that. Isoniazid, or INH, causes peripheral neuropathy. To prevent this, you have to supplement with vitamin B6 pyridoxine.
Ethambutol causes optic neuritis, so you need baseline and monthly eye exams. And preazenamide is associated with hepatitis and hyperuricemia.
We also deal with non-tuberculous mycobacteria, or MSC, from the Mycobacterium avium complex. It's not usually contagious, but causes devastating disseminated disease in specific high-risk groups.
Specifically, advanced AIDS patients when the CD4 count drops below 50.
Treatment is aggressive and long-term. A macrolide plus ethambutol plus rifampin for over a year. Prophylaxis with azithromycin is indicated for those vulnerable patients.
Moving to opportunistic fungi. Pneumocystis jirovecii pneumonia, PCP, is the classic AIDS-defining illness. CD4 count under 200.
It causes severe dyspnea and bilateral interstitial infiltrates, often leading to a remarkably high A gradient and significant hypoxemia. Diagnosis relies on seeing the cyst structure with silver stain.
Treatment is high-dose trimethoprim sulfamethoxazole, TMP-SMX. And if the patient is hypoxemic, adding systemic corticosteroids is life-saving.
Finally, the endemic fungal infections defined entirely by their geography. Knowing the patient's travel history is the key.
Histoplasmosis is the fungus of the Ohio and Mississippi River valleys from bat or bird droppings. Diagnosis is often quick with a urine or serum antigen test.
Coccidioidomycosis is the fungus of the southwestern U.S. desert soil. Valley fever. Blastomycosis is concentrated in the central and southeastern U.S., also around the Ohio and Mississippi rivers. It's unique for its propensity to involve the skin and the prostate.
And treatment for mild disease is itraconazole. Severe disease requires IV amphotericin B.
Let's cover a few specific infectious challenges, starting with anthrax from Bacillus anthracis, an occupational threat for those handling infected animal products.
The most dangerous form is inhalational anthrax. It starts with flu-like symptoms, but rapidly progresses to hemorrhagic mediastinitis and septic shock. Extremely high mortality.
The more common form is cutaneous anthrax, a painless papule that ulcerates and forms that characteristic black escher.
Treatment for the inhalational disease is immediate. Multi-drug 4V therapy, ciprofloxacin or doxycycline, plus 2 other antibiotics. Post-exposure prophylaxis has to continue for 60 days.
Moving to the upper respiratory tract, acute pharyngitis is overwhelmingly viral, but we have to identify the 10% caused by group A strep because of the risk of serious complications.
We use the modified center criteria to decide who gets tested or treated.
Right, it scores for things like tonsillar exudates, tender lymph nodes, absence of cough and fever. If the score is high, the clinical imperative for treating with penicillin is to prevent acute rheumatic fever.
And finally, sinusitis. Acute sinusitis is usually viral. If symptoms last longer than 10 days, we suspect a bacterial superinfection.
Treatment is amoxicillin clavulanate. Chronic sinusitis is symptoms for longer than 3 months. This often requires prolonged antibiotics and surgical intervention.
All right, final section, hemoptysis, pleural disease, and upper airway conditions. Hemoptysis, coughing up blood from the lower respiratory tract, demands immediate triage.
Massive hemoptysis, more than 600 ml in 24 hours, is a life-threatening emergency primarily due to asphyxiation, not blood loss.
The causes are diverse: TB, bronchiectasis, lung cancer, PE. The absolute immediate priority is airway management.
The essential clinical action is to secure the airway and place the patient with the suspected bleeding side down. This minimizes the risk of blood drowning the good lung. Then you get imaging and an emergency bronchoscopy.
Next, pleural effusion. The analysis of this fluid is paramount, classified by the Seminole Lights criteria, separating transudates from exudates.
A pleural effusion is an exudate if it meets at least one of 3 criteria, indicating high protein and/or high LDH. Either the fluid to serum protein ratio is over 0.5, the fluid to serum LDH ratio is over 0.6, or the fluid LDH is greater than 2/3 the upper limit of normal for serum.
And a transudate meets none of these criteria. Why? Because transudates are caused by alterations in systemic forces, hydrostatic pressure like in heart failure, or low oncotic pressure like in cirrhosis.
The capillary structure is intact, so only a thin, low-protein filtrate leaks out. You treat the underlying systemic cause.
Exudates meet the criteria because they're caused by increased vascular permeability from local inflammation, infection, or trauma. This allows large molecules like proteins to leak into the pleural space.
Common causes are pneumonia, malignancy, trauma, PE. Exudates require invasive diagnostic workup like cytology and culture.
Building on that, let's look at the progression of peripneumonic effusions. The fluid chemistry changes as the infection progresses.
An uncomplicated effusion is sterile and resolves with antibiotics alone. A complicated effusion or an empyema, which is frank pus, requires antibiotics and immediate chest tube drainage.
Empyema fluid is highly acidic, with a pH less than 7.2, very low glucose, and a positive gram stain, reflecting high bacterial metabolic activity.
Finally, the critical emergency of pneumothorax air in the pleural space. The ultimate life threat is a tension pneumothorax.
This is a one-way valve. Air enters the pleural space during inspiration but can't escape. The pressure builds, pushing the mediastinum and the trachea away from the affected side.
The result is hemodynamic instability and cardiovascular collapse because the high pressure compresses the vena cava, preventing venous return. This is a purely clinical diagnosis. You do not wait for imaging.
Immediate life-saving intervention is required. Needle decompression in the second intercostal space, mid-clavicular line, followed by a definitive chest tube.
Let's quickly cover 2 critical sleep disorders. Obstructive sleep apnea, or OSA, is physical obstruction from upper airway collapse during sleep. Risk factors are obesity and a large neck circumference.
Patients have profound daytime sleepiness, snoring, choking episodes. The major long-term complications are cardiovascular morbidity, hypertension, arrhythmias, increased risk of stroke.
Diagnosis is confirmed by polysomnography, a sleep study. The key metric is the apnea-hypopnea index, or AHI.
Treatment involves weight loss. The definitive primary treatment is CPAP, which acts as a pneumatic splint to hold the airway open.
The second disorder is obesity hypoventilation syndrome, OHS. This is awake alveolar hypoventilation in a severely obese individual with a chronic high PaCO2 not explained by other diseases.
Treatment requires weight loss and non-invasive positive airway pressure, like BiPAP, to assist both oxygenation and ventilation.
Wrapping up with the upper airway, starting with rhinitis. We differentiate allergic rhinitis and IgE-mediated hypersensitivity from non-allergic rhinitis caused by irritants or structural issues.
Epistaxis, or nosebleed, is classified by location. Anterior epistaxis is the most common, from the Kieselbach plexus. Treatment is direct pressure, topical vasoconstrictors, and packing or cauterization.
Posterior epistaxis is rarer, more severe from the sphenopalatine artery. It requires special posterior packing and urgent ENT consultation, and the source emphasizes a crucial complication. Prolonged packing over 72 hours increases the risk of toxic shock syndrome.
Finally, laryngopharyngeal reflux, or LPR. This is silent reflux gastric contents irritating the upper airway, often without classic heartburn.
Symptoms include chronic cough, throat clearing, and hoarseness. Treatment is rigorous. Strict dietary changes, behavioral modifications, and high-dose proton pump inhibitors.
And one final rare condition, recurrent respiratory papillomatosis, RRP, caused by HPV.
It manifests as warts in the upper airway, causing hoarseness and stridor. The juvenile form is transmitted at birth, the adult form through oral sex. Treatment is repeated surgical debulking. The HPV vaccine is the primary prevention strategy.
We have executed a monumental deep dive into the high-yield map of pulmonary disease. We established that fundamental mechanical difference between obstruction and restriction. We navigated the specific pharmacodynamics of 8 drug classes for asthma and detailed that life-saving shift from alkalosis to acidosis.
And we transitioned seamlessly into critical care, detailing the lung protective strategy for ARDS, that 6 cc per kilo target, and explaining how ventilator pressures, P-peak versus P-plat, dictate whether we treat a clogged pipe or a stiff lung. We connected chronic disease like COPD to vascular failure like cor pulmonale and traced clot risk back to Virchow's triad.
From the specific imaging of pneumoconioses, like eggshell calcifications and silicosis, to the specific paraneoplastic syndromes of lung cancer, the utility of this synthesis is enormous. The respiratory system really serves as a central barometer, linking inflammation, environment, genetics, and circulation into one complex, vulnerable pathway.
So let's end with a final provocative thought that connects the lung to the wider abdominal cavity. We spent significant time on Light's criteria, differentiating transudates from exudates. Our source material listed severe acute pancreatitis, an entirely non-pulmonary disease, as a cause of an exudative pleural effusion. Think about the fluid chemistry. Why would massive inflammation in the pancreas fundamentally change the permeability of the pleural lining enough to cause an exudate?
That specific link tells you that the inflammation is not contained. The intense inflammatory mediators and enzymes released by the damaged pancreas can actually track upwards through lymphatic channels or across the diaphragm, causing a local inflammation of the pleura itself, a chemical pleuritis.
And that localized inflammation drives the vascular permeability, allowing large proteins and LDH to flood the pleural space, fundamentally changing the fluid's properties from a simple systemic transudate to a localized inflammatory exudate.
It's a powerful illustration of how systemic pathology dictates pulmonary pathology, something to keep mulling over as you continue your own deep dives.